Everyone to the of a foundation course in palliative medicine. Today it is going to be very important topic. But let's discuss among doctors, especially wound management. And we have one of the most eminent faculties in the country, the Sheeba herself, joining us to walk us through the session. So without much delay, I hand over it to our esteemed facilitator, Dr. Raka Venkateshan, to introduce the faculty and further take the session. So, ma'am, it is over to you.
And thank you. Good evening, one and all. Palliative care as such is incomplete without nursing care, because as we have been talking through, there are very many elements to palliative care, of which nursing care is a prime important thing, which takes a big share too. So we have to master or at least know about that skill also, so that when we work as a team, we can be helpful in all forms. Okay, so from that point of view, we go into another. See, we are in the process of symptom management. Like, so we deal what are the symptoms that are probably common in palliative care, and then we go on to how are we going to manage them. In that front, nursing care forms a big element. As we always say, a nurse, a social care worker, and a doctor. At least these three are the essential elements to have a palliative care service. So from that point of view, we have an important topic today, which is wound management, for which we have Sister Sheeba to take us through the session, imparting the knowledge and skills that are needed. Sister Sheeba is a section head for the online training section of Palim India, and she has obtained her palliative care course certification from Amrita Institute of Medical Sciences, Kochi in Kerala, and she has worked in Department of Palliative Care at the Regional Center, Thiruvananthapuram. And her main aim or focus is on delivering palliative care training to the nurses and doctors of India, so that once training is done, we have an efficient team to render the service. She has an extensive experience, 18 years of nursing experience, and she's also a certified trainer by the National Health System Resource Center. And above all, she has been recognized as the pioneer nurse by the St. Christopher Hospice of United Kingdom in the year 2020. With this, I hand over to you, Sheeba, to take us through the session.
Thank you, ma'am. Thank you for the kind introduction. Good evening to all. As ma'am said, today we are going to learn about wound management. So let me share my screen first. Hope my screen is visible to everyone.
Yes, Sheeba, you can go ahead.
Thank you.
It's clear and we can hear you too.
So you might have seen different types of wounds in your setting, but in palliative care, mainly we have seen two major different types of wounds. One is pressure ulcer and the another one is fungating wound. Okay, so let me discuss with you the first pressure ulcer. So what is pressure ulcer? What are the major causes of pressure ulcer? The pressure ulcer is a localized injury to the skin and other underlying tissue, usually over a bony prominence as a result of prolonged unrelieved pressure. If there is a prolonged unrelieved pressure there is a chance of breakdown of underlying tissues, especially under the bony prominence. Okay, so that is pressure ulcer. There are three major causes of pressure ulcer. One is continuous pressure. The second one is friction. The third one is moisture. These are the three major causes of pressure ulcer. So let's see what is the pathophysiology of pressure ulcer. So why I am telling this pathophysiology with you all is, so whenever we have seen a patient, seen a bedbound, especially bedbound patients, you have to teach the caregivers, you have to empower the caregivers about the turning techniques and incontinence control and also you have to keep it in mind what is the pathophysiology. You have to tell them how the pressure shock will occur. So you can imagine a patient lying on a bed. What happened? So if there is a prolonged continuous lying in the same position, so the body weight, that means the bone will be compressing the underlying tissues. That time, what happened? So if the tissues are not getting adequate blood supply, the tissues will be collapsed. Okay, so the when the blood vessels collapse, the tissues may not get adequate nutrition. That time the tissue will ischemic, hypoxic, and finally stress and breakdown. So this is the pathophysiology of pressure ulcer formation. Okay, so let's see the risk factors of pressure ulcer. The first one is friction. So friction is one of the common risk factor. And the another thing is this is one of the major cause of pressure ulcer. How does it happen? Usually for a bed-bound patient, we need to change the bed sheets. In the hospital, we have nurses. The nurses will take care of the patients. Nurses, they know how to change a bed sheets from a bed-bound patients and how to put a new bed sheets for a bed-bound patient. But what usually happen when they go back to their home? Usually the caregiver is the primary person to take care of that patient. So they usually change the position. They pull the sheet, change the position, and they usually try to change the bed sheets. What they will do? They will pull the sheets under the patients. That time there is a chance of friction. If there is a friction there is the chance of friction between the skin and linen, clothes. So that time, if there is a small breakdown happen, peeling happen, then if you give a continuous pressure on that area, definitely the skin will damage. And the another thing is shear. So this is because of, you just imagine an obese patient. Okay, they usually slipping downwards to the bed. So when we try to re-back to their normal position, what happened? We usually call 1 or 2, 3 persons and we that pull the patients up. Our idea is good, but that time there is a chance of deep tissue injury happen. So if it is happened there, we don't know whether there is any deep tissue injury happen or not. If you give further pressure on that area, definitely the skin will break down. And the third one is impaired sensory perception and impaired physical mobility. Okay, so here for a paraplegic patients, they are not able to hear the lower limbs will be not able to they can not able to turn. So because of that, that sensory sensation is lost. No, so that time the patient can develop pressure ulcer. Here, impaired physical mobility also. They want to turn independently, but they are not able to turn independently, especially paraplegic patients. They need a help. So that patients can also develop pressure ulcer. Then altered level of consciousness. Either semi-conscious or unconscious patients can develop pressure ulcer because of prolonged unrelieved pressure. And the another problem, again, moisture infection. These are the problem will be there in unconscious and semi-conscious patients. That patients can also develop pressure ulcer. And then fecal and urinary incontinence. So the third major cause of pressure ulcer is moisture. So if there is a fecal and urinary incontinence there, definitely the moisture will be there. So that is also another risk factor of pressure ulcer. And then malnutrition and dehydration. So this is also one of the major risk factor, because if sometimes we change the position every 2 to 3 hourly, we put air mattress or water mattress, whatever is so we usually give massage, but sometimes even then the patients can develop pressure ulcer. Then what is that? So the problem is maybe because of malnutrition and dehydration. So we have to look into that part also. And then excessive body heat and advanced stage. So these are the risk factors of pressure ulcer formation. Coming to the common sites of pressure ulcer, from this picture, you can get an idea. It can occur anywhere. So even supine position, sideline position, so that Fowler's position, and also if the patient is putting maybe sitting on a wheelchair also, that patient can also develop pressure ulcer. From this picture, so what you have to understand is, especially on the bony prominence, but it can occur anywhere, and the body depends upon the patient position. So just see this picture, then you will get an idea. Heel, occiput, scapula, toes, sacrum. These are the common areas which the patients can develop pressure ulcer. So coming to the positions. So this is the one position which we commonly use this position, and the most of the patients can the willing to lying down in supine position. Even if the patient is in supine position also, head, shoulder, elbow, buttock, heel, toes, these are the common pressure points. Okay, so why I am telling these pressure points is, so we need to change the patient's position from supine position to sideline position after 2 to 3 hours. Okay, so if we change the patient position from sideline, that supine position to sideline position, we have to give a special attention for these areas, because if there is any color change there, we need to give special care on that area. We have to prevent further pressure on that area, so that we can able to further damage. So we can able to prevent further damage. And then a sideline position. Here, ear, acromion process, ribs, greater trochanter, so medial and lateral malleolus, lateral contents, these are the common areas. Because this one important thing from this that position you have to understand is between the knees. So when the patient is on sideline position, either right lateral or left lateral position, there is a chance of the rubbing in between the knees are rubbing together, and friction can cause maybe the pressure ulcer formations. What you have to do is, you have to keep a small pillow or a folded sheets in between the knees when the patient is on lying down the sideline position. Okay. And coming to the Fowler's position here, this is one of the best position for controlling dyspnea. But even if the patient is on Fowler's position also, these are the pressure points. You have to change the position at least 10 degree, because so you have to turn the patient at least 10 degree is enough for this kind of patient. No need to put the patient in sideline position or supine position after 2 to 3 hours. At least 10 degree turn is enough for these kind of patients. So our idea is to relieve the pressure for unrelieved. You have to relieve an unrelieved pressure for that area. Okay. So coming to the prone position. Coming to the prone position, so these are the major points: head, elbow, chest, reproductive organs, knees, and toes. So here, this is a very rare position, but sometimes the surgeon will be done. Maybe the surgeons will be planning to do the skin grafting procedure for some kind of patient. That time, we usually train the patients before they undergoing the surgery. So because after skin grafting procedure, they need to lying down this prone position at least 3 weeks. So before they going to surgery, we will train the patient in prone position. Even if the patient is in prone position also, the patients can develop pressure ulcer. Okay. Coming to the stages. So there are 6 stages of wound. The first stage is non-blanchable erythema. From this picture, you can understand there is a red color. So that means this is a non-blanchable erythema is the first stage. Okay, so if you have seen this kind of color change in that area, you can give your finger pressure on that area. Then usually if when you give a finger pressure on that area, you usually the blanch will be there, but it will, if there is a stage 1 pressure ulcer there, it will not blanch. So that is the stage 1 pressure ulcer. Okay, so from for this the stage management is to prevent further pressure on that area. So that way we can able to prevent that further damage. Coming to the stage 2. Stage 2 is partial thickness ulcer or shallow open ulcer into the dermis. The dermis layer will break down or the blister formation will be there. Okay, so partial thickness or the dermis layer will be breakdown or a blister formation will be there. If there is a blister formation there, definitely the skin, the blister will burst and the dermis layer will damage. But there is no pus, only clean wound is there. So that these kind of wounds you can clean with normal saline. Coming to the third stage, full thickness ulcer. All subcutaneous layers will be included. Sometimes tunneling will be there. So tunneling means a narrow opening or a passageway that can extend in any direction through the soft tissue. This is very, very important. If the wound is having tunneling, so if you are not give much attention on that area, the wound won't be healed properly. So when you assess the wound, you have to check whether that wound is having any tunneling or not. If there is tunneling there, you have to give special attention on that area also. Coming to the stage 4, exposed muscle, bone and tendon. So these are the bone, muscle and tendon will be involved in the stage 4. And the 5th one is unstageable wound. Unstageable means you can see this picture. So we can't say this might have stage 4 or stage 3. So this is unstageable. What is unstageable? Unstageable means pressure sore is unstageable if it is a slough form and or eschar on the top. If there is a black necrotic tissue on the top of the wound, we can't assess the stage. That time you can say unstageable. When you document it, you have to document it as an unstageable wound. And the 6th one is deep tissue pressure injury. So how does it happen? It happens from a shear. Okay, shear force. So I already said one of the major risk factors is friction and shear. So from the shear, if there is a shear force there is a chance of deep tissue injury. Here the color is maroon discoloration. There is a purple or a maroon discoloration there. So this is the non-blanchable deep red thing will be there. So here the tissues damaged from inside out. Okay, so inside already damaged and finally the skin will exposed. So this is the deep tissue pressure injury. So we have learned there are 6 stages of pressure ulcer. The first one is non-blanchable erythema. The second one is the dermis layer will be breakdown that or a partial thickness. The third stage is full thickness ulcer. The 4th stage is muscle, bone and tendon will be affecting. And the 5th one is unstageable wound. The 6th one is deep tissue pressure injury. So these are the common stages of pressure ulcer. Coming to the assessment. So doctor and nurse must assess the patient's skin at each visit of a bedbound patient and a wheelchair patient. Even every visit you have to check the patient's at least pressure points, whether there is any discoloration or not. You have to check it that and assess the pressure points and assess the pain associated with wound. If there is already there is a pressure ulcer there, you have to prevent further the development, and also you have to check with the patient about the pain score and all. So because this is a subjective experience, you have to ask them whether there is any, whether they have any pain or not. If the patient is having pain, you have to give some analgesics for that, and then you have to do the dressing. Assess location, measure width, length and depth of the wound. So approximate width, length and depth of the wound, and stages we already understand about the stages of wound. Presence of exudate. Exudate means the oozing out of fluid or a purulent discharge from the wound. Assess for tunneling, and all these details you have to document it properly, because maybe first time you might have seen this that particular patients. Maybe next time your colleague will be seeing these patients. If you document it properly, from your report, from your documentation, your colleague will get a good idea, and also they can able to do the follow properly. So the documentation is very important. So coming to the management part, the always medicate the patient for pain before wound care. I already said this is one of the major part. So we all learn the major aims of palliative care to relieve pain and other symptoms. If the patient is having pain, you have to give some analysis for that, and then you can do the pain management. Then you can do the wound management. So coming to the stage 1 management, here is a non-blanchable erythema. That time what you can do is you can teach the caregivers to turning techniques and excellent incontinence control. So that is the only way to manage the stage 1 pressure ulcer. Here we sometimes if you give further pressure on that same area, there is a chance of damage into the tissues. So here, if there is a non-blanchable erythema, you have to prevent further pressure on that area. Coming to the stage 2 pressure ulcer, so there is no pus formation, there is no slough, only clean wound is there. That time you can clean with normal saline, that is enough. Coming to the third stage and fourth and unstageable wound. So if there is a slough there, you can do the surgical debridement. Okay, if there is a black necrotic tissue there, you can remove with that. Then use normal saline for wound cleaning. So always you have to educate the patient about the wound cleaning, and you have to demonstrate to them, and also you have to train the patient how to make a homemade saline also. So I will come to that later. If there is an odor or infection there, you can advise them to use sprinkle metronidazole powder. So same metronidazole tablets, crush it and make it a powdered form, and mix with a white petroleum jelly or a Vaseline and make it a pasted form, and then apply on the wound. So that the wound will get two benefit. Metronidazole will try to control the infection, and the white petroleum jelly will give a moisturizing effect to the wound. So that the wound heal will fast. So here you have to keep it in mind. And another option is debridase ointment. And and next is Megagil ointment. If there is a lot of the necrotic tissue there, then you can use debridase ointment. Once the slough is removed, then you can apply Megagil ointment. Usually our surgeon prefer these kind of ointments. We usually use metronidazole tablet. That is the one the medication for controlling the anaerobic bacterial infection. So that is the drug of choice of controlling anaerobic bacterial infections. If that medication is not helpful, then you can think about the another options. Then charcoal. So this is one of the good thing for absorbing bad smell, especially the stage 4 pressure ulcer. There is a stage, sometimes stage 3 also, because of the necrotic tissues and exudates can cause a lot of smell. So that time you can think about charcoal dressings. Yeah, the charcoal dressings is very expensive. But at the same time, you can make advise the patient to make charcoal pieces into their home and keep 1 or 2 pieces in their room. That will help to absorb the bad smell. So they can make a charcoal. They can at least a coconut shell. They can burn it and make a charcoal, and then that will help to absorb the smell. So you can advise them for that. And here one important message I convey with you all is avoid a hypochlorite solution like powdered iodine and hydrogen peroxide solution. So why it should avoid? Any idea? We are not preferring any hypochlorite solutions for wound cleaning. Why? Any idea? Anybody? Okay, ma'am. Burning sensation. It can harm good tissues as well. Okay. Thank you. It will increase pain. Thank you. Irritation. Thank you. Thank you for your contribution. So, so this is on this kind of solutions are irritate, and also it will destroy the granulation tissues. So, if you use these kind of solutions into the wound directly, definitely if there is a granulation tissues there, that tissues will destroy. So that is why we prefer normal saline only. If sometimes the surgeon will, if they during the consultation time, they will tell like, so you can clean with powder nitrate solution, but at the same time, they will tell us you can, if you use powder nitrate solution, you please dilute with the normal saline and then use, not concentrated one. You can dilute with that normal saline and use powder nitrate solution if you want. But after cleaning with the diluted that solution, we usually clean with normal saline. So this will destroy the granulation tissue. That is the main reason for that. And then surgery consultation. So finally you have to think about the surgery consultation. If the patient health status is okay, then you can think about that, because sometimes stage 3 or stage 4 pressure ulcer, we can't manage fully. So that time, if the patient is okay for doing the surgery, then you can think about, you can do the surgery consultation. And if the surgeon requests to do the skin grafting procedure, then you can think about that also. And the final management is negative pressure wound therapy. So there is a machine there. So this is done with a machine. So this machine, if you do like this, it will help to absorb it will remove the exudate from the wound and give a continuous stimulations. That will help to improve the wound healing. Coming to the homemade saline and dressing supplies, here we within the hospital we have normal saline. We usually use normal saline for wound cleaning. So and also at the same time, when they go back, they have to clean their loved ones' wounds, because sometimes they are not able to buy normal saline from the medical shop. That time you have to teach some home remedies too. For homemade saline, they can take 500 ml of water and add 1 teaspoon of salt. So boil it, cool it, and then they can use that same normal saline, clean normal saline for wound cleaning. These kind of wounds are not a surgical wound. It is it's a clean wound. The clean saline is used enough for wound cleaning. And the another thing is dressing supplies. So this is also important things. Whenever you have seen these kind of patients, you have to teach some home remedies like dressing supplies. They can take a cotton saris or dhotis cut into squares and steam it. Okay, so they can steam it at least half an hour. So after that, they can use that the dressing materials for wound dressings, because you can just imagine that COVID for that 19 time, that 2020. So that time the shutdown, the total shutdown were there. So what happened? Our the by all the health system is also that the thing is we are not able to provide dressing materials to the patient's home. So that time we usually train the caregivers and the patient about how to make dressing materials in their home. We already done for that. So that time they were managed this way. So after 3 weeks, we were not we were able to give provide dressing materials, but in between they somehow they managed. And the prevention. So this is one of the major thing. Prevention, we all know that prevention is better than cure. So here for a bed-bound patients, whenever you have seen a bed-bound patients, so you have to always think about how to prevent, what are the ways to prevent pressure sore formation. So this is very, very important. First, you have to think about position change. Every 2 to 3 hours for a bed-bound patients, we have to change the position. Even wheelchair patient also, they have to relieve their pressure every 15 to 20 minutes. And manage incontinence. So if they have an incontinence, maybe incontinence of urine there, if they are willing to put a catheter, you can put a Foley's catheter and drain the urine. Or if they are not willing to put a catheter, then you can advise to use diaper. That also they have to change whenever, because long time is not good. So they have to change in between that diaper also. And if they are not affordable to buy a diaper, then they can use their own sheets. But the thing is, if the sheet become wet, they have to change and replace a new one as soon as possible. That is also important. And you can suggest some special mattresses, air mattress or water mattress. But the important thing you have to tell them is, if you provide air mattress or water mattress to the patient, they might be thinking like, though this kind of mattress will take care of everything. After that, they will not change the position. If the patient is on water bed or air bed, the patients, if you are not turn the position, if you are not change the patient position to the patient, definitely the patients will get pressure ulcer, because in between the rows, for a air bed, there are different rows are there. One rows will be inflating and the another, the alternate rows will be deflating. So there is a alternate pressure relieving there, but the thing is, in between the rows, there is a there will be continuous pressure. So that time the patient will develop pressure ulcer on that area. So this is one of the pressures of preventing, helping measures, not 100% preventing pressures or measures. They will help us to prevent pressures of formation. So whenever you suggest these kind of matters, you have to tell the caregivers about the importance of changing your position also. And you can think about pillows and cushion also for the comfort of the patient. And nutrition, hydration, and exercise. So this is also important. If the patient is not getting adequate nutrition, like a protein intake, lack of protein intake, their diet can cause pressure ulcer formation. If the patient is not getting any kind of exercise, like if they are not able to move independently, that may be a passive exercise will helpful for these patients. If you do the exercise, that will help to improve the blood circulation, and that way we can able to prevent bed sore formation. And massage. Whenever we turn the patient from one position to another position, you have to look into their pressure points, and then you can take a liquid paraffin or white petroleum jelly or even coconut oil and give a good massage on that area, that way we can able to improve the blood circulation on that particular area and prevent pressures of formation. And always give a wrinkle-free bed. So if there is a wrinkles present in the that bed sheets can cause pressure ulcer and even delirium also. Nail care is also important. If there is a that long nails there, they will scratch into their own skin, and if you give pressure on that area, again the patients will develop pressure ulcer formation. So this is a small tip for you all, is how to prevent pressure ulcer, SKIN. Whenever you have seen these kind of patients, always you have to think about SKIN. The first S is supporting surface. You have to think about your patient is having the patient is lying on a good supporting surface. So you have to think about air mattress or water mattress or pillows, cushions, whatever it is, you have to think about. And then skin inspection. So whenever we turn the patient from one position to another position, you have to check the pressure points. The regular skin inspection is also important. And the another thing is K. K is keep moving. Every 2 to 3 hours, we have to change the position. And the I is incontinence or moisture control, bladder and bowel care is also important. And now N is nutrition. Nutrition and hydration is also important. So they must have to take a good diet, like especially protein intake and fluid intake. So that way we can able to prevent pressure formation. So and also we have to think about how to engage the patient and family for preventing pressure. So this is one of the major part, because within the hospital we all are there. Our nurses will take care of the patient, and the nurses will that give a good massage. They will change the bed, the sheets. All nursing care will the nurses will do. But when they go home, the nurses do not there, doctors will not be there, the caregivers will be doing the patient care. So that time what we can do is we have to try to give a good rapport with the patients, because without them we can't do anything. So if they have a good rapport with us, definitely they will provide a good care to the patient. Okay, so how to make a rapport with the patient? Because we need to develop a contact with them. So we usually use the term you. You should do like that. We usually, that's a common word, you. You should do like that. You should turn the patient position every 2 to 3 hours. You should apply some massage or the oil on that that contacted skin, that kind of thing. So that kind of things, we always use the term you. Instead of you, you can use the word we. If we use the term we, so they feel like, okay, somebody is behind them to support us, and that kind of feeling will be there. So so if you use the term we, definitely they might have a good relationship with you, and then if they have any doubts, definitely they will ask you, because there is already they have a good rapport with you, and then definitely they will ask you. And also you can think about some patient information leaflets. Okay, so this is the Malayalam leaflets. If you make these kind of leaflets after education and demonstration, then if you give these kind of things, if they have any doubts, there they will go there and look into this that leaflets. This will help to improve their knowledge. So we have a small video on that. We will show you that video, what are the ways to prevent pressure ulcer and all. So after that, I'll come to the fungating. Hope this video is help to everyone. Okay. So then we can move on to the fungating on the cancer on. So I would like to ask one question with you all. What is the major difference between pressure ulcer and cancer on? Either unmute yourself and talk, or you can put your answer in the chat box. So what is the major difference between pressure ulcer and fungating wound or a cancer wound? Harini ma'am said these edges, okay, difficult to heal. Pressure ulcer mainly happens at pressure points. Fungating can happen anywhere, okay. Irritation is more dry, okay. No tunneling. Any other answers? Wound edges are different, granulation tissues also, okay. So come to that. Fungating is slow to heal, pressure ulcer heal well as soon as pressure is removed, okay. Okay, thank you. Thank you for your answers. The pressure sore we learned. So pressure ulcer is most of the time is preventable and curable. But in fungating wound or a cancer wound, we can't prevent, and its healing is not that good, because not healing ulcer will be there. Non-healing ulcer is not curable and not preventable. So this is the major difference between the pressure ulcer. The pressure sore is preventable and curable. So the cancer wound is not preventable, not curable. So this is the major difference between pressure ulcer and the fungating wound. So here it is a primary or a secondary malignant growth in the skin which has ulcerated and difficult to heal. So this is the definition of fungating wound. The term fungating refers to a malignant process involving both ulceration and proliferative growth. So at the same time, the proliferation and ulceration will be happen. There are a lot of necrotic tissues will be there. There are a lot of physical problems will be there. So exudate will be, because of that, lot of exudates will be there. And it look like a nodular fungus or a cauliflower in shape. So because of the nodular fungus shape, we call it as fungating wound, this kind of cancer wound, we call it as call these kind of wounds as fungating wound, not because of fungus. It look like a nodular fungus shape. That is why we call fungating wound. Coming to the pathophysiology, we all know that develop a non-tender skin nodules. Gradually, the skin nodules will enlarge. If the skin nodules enlarge, what happens? The disruption of capillaries and lymph vessels will be there. Then altered coagulation and disorganized circulation will be there. Finally, tissue hypoxia and necrosis will be happen. And another thing is Marjolin ulcer. How, I don't know how many of you have seen Marjolin ulcer. I have seen two patients like this. So Marjolin ulcer is a type of malignancy of the skin. It's a malignant changes in a chronic, okay, like from a bone scar ulcer or a pressure ulcer or venous leg ulcer. It's a type of malignancy of the skin. The little bit different pathophysiology is there. Appearance of mass in the wound, onset of that wound pain not previously present. But previously there were no pain when we touch the wound, but gradually the pain will develop, and the patients will say like, okay, I have pain on my own. That kind of things will be there. So that changes will be there, and then change in character, volume, and appearance of drainage will be there. If these kind of changes there, what you can do is you can take a biopsy and said better you can refer the patient to the oncologist, and they will take a biopsy and confirm whether there is any Marjolin ulcer or not. If this is a curative possible cancer, if these kind of changes there, you can refer the patient to the oncologist and make sure that whether there is any Marjolin ulcer or not. If they have some kind of things there, they have to take the treatment for controlling that problem. Coming to the problems, there are this is non-healing ulcer. physical, psychological, social, and spiritual problem will be there. We all know that. From the beginning onwards, we learned about palliative care. Palliative care is not only for the patients, it's for the family also. We always try to relieve pain and other symptoms so that we can able to improve the quality of life of the patient and the family. So here, let's see what are the physical problems might have developed and what are the psychological problems, what are the social problems, and what are the spiritual problems. Coming to the physical problems, pain. So this is one of the main problem because you have learned about two different types of wounds, types of pain, nociceptive pain and neuropathic pain. Sometimes the patients might experience two different types of pain. When we assess the patient's condition, like especially wound, you have to check whether the patient is having neuropathic pain or nociceptive pain, because one is because of direct exposure of dermis. That time the patients can experience nociceptive pain. The another thing is the tumor will be compressing the major blood vessels and nerves. That time the patients will experience neuropathic pain. So if you assess well, definitely we can able to manage, and so the management will be different for different types of pain. No, so when you do the proper assessment, definitely you can treat accordingly. And then coming to the then is the malodor. Malodor is also the main problem because it will be affecting the patient family too. So if there is a huge order in their home, so that all family members will be affected with that, and all because of that. So if the malodor is not controlled well, so the patients will be affecting emotionally because of the the ways the patients can develop malodor. One is the necrotic tissues. Because of the huge, the proliferative tissues will be there. Because of the necrotic tissues can cause malodor. And the another, the thing is, stale exudate dressings have been placed in more number of days. That can they were not able to change the dressings properly. Maybe the same dressings will be there for number of days. That time the patients some malodor will develop, and bleeding. So bleeding is again the dressings are usually the dressings are adherents to the wound. So before soaking the older dressings, when we try to remove the dressings, the patients can develop bleeding. Okay, and the another thing is the tumor will be protruding the major blood vessels. So that way also the patients can develop bleeding. So that is very, very important. You have to do the proper assessment, and if there is any chance of that profuse bleeding there maybe happened there, so there is a you have to prepare the patient family well, because especially head and neck cancers, that is very, very important. If there is a that profuse bleeding occurring into their home, so what they will do, we have to teach the patient family too. And exudates. So because there are the vasodilatation will be there. Because of that, the lot of exudate will be there, itching will be there, infestation with maggots will be there, and then communication difficulties. So because especially head and neck cancers, they are not able to talk to you fluently. They are not, because of the cancer. So what you can do is, if they are able to write down their problems, you can give a sheet of paper and ask them to write down their problems, so that we can able to get a good idea about that patient problem. Okay, and coming to the psychological problem, altered body image. So this is also important. You can imagine a patient with a buccal mucosa cancer. So and also you have to think about the pimple in your face. If the pimple is become large, what you will do? If you get a chance, if you get a chance to see the mirror, how many times you go there and see that pimple? Whether there is whether my pimple size is enlarged, Is there any mark happened? That kind of the thinking will be there, no? So just imagine a non-healing ulcer. The size will be increasing, lot of necrotic tissue, lot of problem. So that time, that how much emotional problem will be there. So altered body image is also affecting the patient, that emotionally, socially, and spiritually too. And sexuality will be there, and the sexuality will be affecting because of the misconception of disease. Denial will be there. Sometimes positive denial will be there. Sometimes negative will be denial will be there, because they were sometimes they are and they understand well, but at the same time they will be arguing with you. The wound size is reducing. That kind of thing will be there. They will be arguing. So that time, what you can do is just listen, not take it as a challenge and make them understand that this wound is not going to heal like that. So you can listen. At least you have to listen and leave them. You can do the dressing and leave them. Then gradually they will understand. And fear will be there. They will be anxious and depressed. So because why I'm getting these kind of disease that is not controlling. So lot of problems, shame will be there, and guilty feeling will be there. Coming to the social, family isolation, because these kind of the ulcer, one person can develop this kind of ulcer. The family members will choose a corner side room and keep the patient there. So that is also affecting the patient emotionally. So they were not able to, will not be allow the patient to enter into the kitchen and dining area and all. So they keep the patient always there in that particular room. And social isolation, friends and relatives, especially neighbors, are not willing to see these kind of patients because of the misconception of disease. Social stigma will be there, fear of contagion. This will be affecting the family, the whole family members, and also affecting sexual relationship and marital disharmony, because nobody is willing to take marry these kind of the diseased condition family, because maybe misconception, and another thing is they might be thinking like a hereditary factor. So this kind of thing will be affecting the patient emotionally. Because of me only, my daughter is not getting married. So these will be affecting the patient the psychologically and spiritually. And coming to the spiritual interference with religious rites, punishment from God because of my sin, God punished me like this. These kind of spiritual questions and thoughts will be there. Coming to the assessment part, so this is also the same way we have to assess. When we do the assessment for this kind of wounds, you have to think about is there any mobility involvement there, or we can able to covered with public view, because nobody is willing to expose their wound to the public. Okay, so I still remember on patient. He was having buccal mucosa cancer, and when we come to us for cleaning and dressing, he used to bring the long towel. So I was asking him, why you bring this kind of long towel with you always? Then he told me like that, if I don't have this kind of long towel with me, nobody is willing to sit near to me, because he used to do travel. So he, after dressing, he wants to travel in a local bus, the transport. So if anybody has seen these kind of wounds, nobody is willing to sit near to him. So after dressing, he used to cover his face with a long towel. So that time, nobody is know this patient is having a wound or not. So he used to tell that told me like, so whatever you can wear, so you can cover the wounds, only wound. So because if anybody is maybe outside the public view is on the important fact inside his mind always. If the dressing materials is seen outside, they will be seen the dressings, no? So that is also important. So they used to cover the dressing after dressing, they used to cover the whole dressings, the whole face, in that his that towel. So that is one of the coping mechanism. And then wound appearance, surrounding skin, potential for complication. So this is also important, especially I already said, especially head and neck cancers. So there is a chance of bleeding. The tumor will be protruding the major blood vessels. We have to train the caregivers about how to take care of that time, how to take care of the patient, and how to manage even if there is an accidental hemorrhage there. That is also important. And the one important thing I want to say is, if you do the assessment, if possible, you can do the individual assessment. If in front of the caregivers, nobody is telling the truth, they will be hiding the truth in front of the caregivers. Even if they are not take care of the patient well, even then the patient will telling you with, okay, like, oh, okay, she will take care of me well, that kind. If you do the individual assessment, nobody is will be telling like that. So they will be telling the truth. If possible, you can do the individual assessment. Coming to the management, the principles of management is palliation of symptoms, controlling the symptoms, reduce like pain. There you can try to reduce the pain. If there is an order or infection there, you can control the order. And if there is an exudate there, you can try to manage exudate and minimize bleeding. Holistic care is also total care. These kind of patients need a total care. So you always think about the 4 aspects care and empower the patient and family in wound care. Criteria for wound dressing is the goal of care is to improve the quality of life of the patient through symptom control. If you are able to do the good, give a good symptom control to the patient, definitely we can able to improve the quality of life of the patient. Always you have to think about the patient side. This kind of patient need an empathetic care. Always the patients need an empathetic care, but here this is a non-healing ulcer. The symptoms will be worsening day by day. So these patients need an empathetic care. So you have to put yourself into their shoes always, and you can try to do something for the patient and provide a thorough bath for the patient before wound dressings. If they are able to take a thorough bath, you can try empower the patient or encourage the patient to take a thorough bath, because these kind of wounds are fragile. So a lot of necrotic tissues will be there. If they take a thorough bath, all necrotic tissues will follow. Okay, so after that, you can able to clean the wound with normal saline and apply metronidazole powder. Always you have to think about the pain management and use normal saline for the dressing, cleaning, and the dressing based on the size of the wound and exudate, you can think about the dressing materials. Coming to the management of pain, here deep pain and superficial pain will be there. If the patient is having deep pain, then your systemic analgesics will be helpful. And if they have a superficial pain, like a neuropathic pain there, then your systemic analgesics may not help. Then you can think about local application like sensorcaine or lignocaine. Coming to the malodor management, daily cleaning and dressing is essential. And then you can think about local metronidazole powder. And also you can think about injection metronidazole irrigation, because there are a lot of pocket formation inside these kind of wounds. If you use metronidazole injection, the injections will go inside the pocket formation area, and then that way we can able to control the infection. And systemic antibiotics, so you can try one course of antibiotics for that, because especially superficially the blood supply is not sufficient. It may not help fully, but at the same time, one course of antibiotic you can try. And frequent change of dressings based on the say exudate level and the size of the wound. Here also no hydrogen peroxide and betadine. It will not help. It will irritate the wound, and it will affect the patient. It will induce pain also. And also you have to think about charcoal dressings. The charcoal is one of the good agent for absorbing the smell. You can keep charcoal into the bed or under the patient's sheets, or keep it in the corner of the room. That will help to absorb the smell. And also you can think about charcoal dressings. Coming to the bleeding, always try to prevent bleeding. Before removing all dressings, you have to soak with normal saline or water, and then you can try to remove the dressings. Otherwise, the dressings will be adherence to the wound. That will, if you don't wet that wound, soak the dressing, it will cause pain and other thing, bleeding. And if there is a small bleeding there, you can apply local pressure on that area. If the local pressure is not enough, then you can think about sucralfate powder. That same sucralfate tablet which we are using for peptic ulcer, problem. So the same tablet, you can crush it and make it a powdered form and apply on that bleeding part. And then you can think about tranexamic acid. The same way we can crushed it and make it a powdered form and apply on that area. And then if the bleeding is not controlled, then you can think about systemic ethamsalate. Then palliative radiotherapy. If you do the palliative radiotherapy, if the patient's health condition is okay, then you can think about that. If you do the radiotherapy, that will help to strengthen the size of the tumor, and then that way we can able to prevent the growth, protruding, that maybe sometimes the tumor will be protruding the major blood vessels. That kind of things we can prevent. And always you can train the patient about dark color clothes. If there is an accidental hemorrhage there, they always use dark color cloth for wiping out the blood, wiping of the blood, because otherwise the others will panic and anxious about that. If they use white color cotton or white color the clothes for wiping the blood, so that will be again then maybe anxious. They will be anxious and they will be panic. So always you have to think about dark color cloth also. Coming to the role of cancer therapy here, as I already said, radiotherapy, cytotoxic chemotherapy, hormone therapy. So these will help to strengthen the size of the tumor. This the short the time they will help to control bleeding and maybe other problem also. If the patient's health condition is okay, then you can think about these kind of things. And surgery, debulking surgery is also available. If the patient is fit for surgery, then you can think about the debulking surgery also. Coming to the maggots prevention and management. So we all know that how does maggots come? Here the maggots are come from house flies, but the caregivers and the patient doesn't know. You have to educate the patient and the caregivers about the importance of covering of the wound. So if the infected wounds are there, the house flies are attracted with that, and when they touch the wound, they may lay eggs. Within 8 to 12 hours, they come out with maggots. So this is one of the important message. You have to educate the patient and the caregivers about the preventing maggots formation. If there is a maggots there, then you can use turpentine oil, and you can use take turpentine oil and soak the turpentine oil with the gauze piece and keep close to the wound. So that time the maggots will come out. Then you can the physical removal only is the only way to remove maggots. You can remove the maggots from the wound with the help of artery forceps. And another important message I want to convey with you all is don't follow maggots. I already said there are a lot of pocket formation inside this type of wound. When you go with your artery forceps, they go inside and keep safe inside there. If you follow maggots, we don't know whether the maggots is there or not. Your artery forceps will damage the blood vessels. When the maggots come out, you can take it out. Otherwise, leave there. So after few minutes, they will come out. Definitely, because of the turpentine oil smell, they will come out. You can take it out. Okay. So this way we can able to prevent maggots and manage maggots. Thank you. Any questions there? Thank you.
Thank you very much, Shiva. This is some like the whole wound management, everything, no, is something essential which everyone needs to know, because once we start dealing with palliative care patients, many of them, or at least some stage of their disease, they will become bedbound. Very few, like as we see the four trajectories in the end of life type of situation, many, only very few don't get to the stage of being bedbound. So this is, we need, everyone needs to be aware, not that every patient will develop bed sore, or not that every malignancy patient will develop fungating wound, but these are the most common. So if we don't know how to manage, or if we are not aware of these things, the whole thing will not be complete. So that is one important thing. So thank you very much for taking through this topic in detail. It's not that as doctors we need not know, we need to know about all these things to educate our team, and most importantly raise awareness in the caregivers and families. So few important points which I would like to reiterate, or like take home, what I would like to say is that, first thing what she said, see, wound care, wound management is something which many patients will be afraid of, apprehensive. If you touch, it will hurt. Okay, these are things which are very common. Anyone who goes through that stage will be there. So couple of things which you can do to avoid this. She said using your painkillers, analgesics, what you're using, give them 40 to 45 minutes ahead. See, sometimes very many know when you're going to do it. So you can give instructions to the carers or family that, for example, if you're anticipating the team to come around, or they are going to come to hospital anywhere, 11 o'clock is what they're expecting to have the change of dressing or something like that. Ask them to give oral painkillers an hour, 45 minutes. See, oral, what is, how long gastric emptying time, or how long does it take to get the peak effect? So use that and give the painkiller. If they, whatever they are using, they are on Ultrastat or Tramadol plus paracetamol. So give that 45 minutes to an hour ahead. And then what you do, so that at that time you time your dressing to be happening, so that is helpful. Okay. And then the next thing is that, another thing important what was mentioned is, soak the wound, soak the dressing, because anything, if it is hard or dry, if you're peeling that off, it will be painful. Okay, so that is something very, very important. These two will help in having a comfortable, pain-free wound dressing. Next thing is your home remedies. Affordability. Just because of non-affordability, they may be not willing to do the regular or frequent dressing. So if you teach them to use dressings which could be made at home, saline which could be made at home, all these, even oral mouth care, we teach them to make those solutions. Not necessarily they have to buy something every time, because you have to see, patients who can't, financial stress and strain, and that element is a big thing to be considered. So if you teach them home care measures, and they are very, very useful. See, as I said in the beginning, Sister Sheeba has 18 years of experience, and we have all been in this field. And for example, I have taught patients these things. For example, fungating wound for a patient who had a CA breast, and just with the things before, they were not aware, oh, we can't afford. So once we taught them, in few weeks the whole wound was so much better, no odor, and they themselves see the benefit, and you can see the wound healing very well. So the sterilizing, either with a nice clean cloth, you ask them to cut, or if some people say that they can afford to buy gauze and cotton separately, we teach them also exactly to cut, put, like, for example, you can lay the gauze, put the cotton inside, uh, get that cut, put that into containers. And see, our pressure cooker is what we use. Okay, at least 8 out of 10 will be having that, or some form of, see, even if pressure cooker is not there, as she said, steam and heat, and how you teach them all these things. And metronidazole powder and making it into a paste with the petroleum jelly, liquid pattern water, that is also very helpful. As I said, with metronidazole powder and the homemade dressing, wounds will heal well. So these are some things which all of you, is something which you would say the best element to take home from this and use it in your practice. Teach your nurses, and how it could be done will be very helpful from the patient point of view. So that, and odor management is something many people, many situations, what will happen, no one will enter that room. Why? Or they will not allow that patient to come into a common area where all the others are there. So that is all something which will break their emotion to a very great extent. If you can teach them how to manage these things, the whole family can be together. Just because of this, they will not be allowing people, either the patient, to come into common areas, or people will not be going in and being with them, close to them, and things like that. So, and charcoal for odor management is very helpful and useful. So all these things, you need not go for something which is very expensive always. If there is something which can achieve the same with the other alternative. So these are some things which are very, very important. And as Sheeba has mentioned, these are things which all of you have to be aware of. And the whole topic has been dealt with in detail. Are there like any queries you can type, or you can unmute yourself and ask too. We don't have a case presentation, Sheeba, unfortunately. So
I know.
So that's why, like, I would say, like, they can bring up something what they have seen in their practice, or difficulties they've faced with managing these type of wounds. Anything like that, anyone could bring up what, or even see, either sometimes it could be an experience, some personal experience which you would have had. You can bring that up too, if you feel comfortable. It is entirely in your perspective to bring up things which is of concern. It could be something simple. That's okay. Diabetic ulcers. Yes. Diabetic ulcers, exactly. You would follow all the things which we have discussed today. Sheeba, you want to add on something? Go ahead, and then we will come to.
Yeah, ma'am, for the diabetic ulcers, you just think about the diabetic control thing. And once you control the diabetic, maybe the blood sugar level, then only we can that controlling. Maybe you can think about the healing also. The diabetic management is also very, very important. If the wound is there, the management will be little bit different. Might be you can do a surgery consultation for that. That is the way to manage that kind of diabetic management. But you can think about this mega heel ointment, or this another kind of the ointments you can write, but it is not help if you think that kind of ointment is not helpful for that wound, then you can do the surgery consultation, or a good you can think about a good diabetic management. Ma'am,
Yes,
What do you think?
exactly. Yes. The main thing I would like to add on a couple of things. See, as Sister Sheba mentioned, there is very clear evidence. Okay, the glucose level, and that glucose level is directly related to the wound healing and pain also, because they have found very clear evidence on these two. Even for example, as we say, your wound healing, everything depends on your blood sugar levels. So they have said glucose levels have direct impact on healing and also the pain. So that is how we in fact see, we all know that diabetic neuropathy is very common. Okay, and the ulcers are also common in the peripheries, where the microvasculature is the primary cause, and microcirculation is affected there. So it is important to this, you have to impart to the patient and the family why the stress is given on diabetic control. If the diabetic control is not going to be good, you are not going to achieve a good wound healing and pain management also. So both are essential. So that has to be taken into consideration. Otherwise, general wound care and things, wound debridement may be needed, and it will be a long drawn process. It may not be a short, quick response element, and gangrene also can happen. So that is why, as we always say, no, diabetic foot, as Sister Sheba mentioned about looking at the mirror, we teach diabetic patients to look at their feet as they would look at their face. You have to do regular inspection. All the elements, all the risk factors, or most of the elements of risk factors what Sheba mentioned are there. Lack of sensation, and already neuropathic element is there. So these things, even if there is a cut or an injury, they may not perceive it. And we also teach them not to walk barefooted, so they can have some slipper or something inside the house, because when they are not going to be aware of the injury, once the injury happens and it goes on into further, then secondary bacterial infection, all those things are there. So those have to be kept in mind when you, both sugar control is very important, and all other elements, wound, like the skin care, nutrition, hydration, all those are important. And then when you see that they, or you're not seeing the appropriate response, then definitely you would need a consultation with a surgeon. Are there any alternative means of in like increasing the wound healing or reducing the duration of time? Is there something quickening of the response? What are the other skin grafting? So many options are there depending on that particular stage of the wound. So there, surgical help will come handy, and that will be useful. There was something in the chat. Some people may be sensitive to metronidazole powder. What is the alternative? Allergic to metronidazole, is that what Dr. Meera is trying to say?
Can I add?
Yes, I think. Yes,
Yeah.
yes. Go ahead,
So,
Shiva. Yes,
yeah.
they mentioned about allergy.
I had mentioned earlier about metronidazole. The metronidazole is one of the good medication for controlling anaerobic bacterial infection. The drug of choice of controlling anaerobic bacterial infection is metronidazole. Even then, sometimes the metronidazole not good, maybe not enough to control, maybe not enough to heal that wound. Then if you think like that, if you do the proper assessment for proper follow-up, if you think like that, then you can think about the alternate ways, like debridase ointment and megagil ointment. There are a lot of ointments that are available. Then you can think about that way also. This is not a only way to that to heal the wound. This is the good agent for the controlling this kind of infection. And the another option, another important the thing is, this is very cheap and cost effective. So that is why we think about metronidazole first. And always, if they are affordable, you can think about debridase ointment, becagil ointment, and all. There are a lot of ointments are available. So first, this is you can think about the cheapest one, and the people may be affordable for this. If you suggest these kind of things, definitely they will buy and do the dressings. So that is why we prefer metronidazole first. And also, this is a good agent for controlling anaerobic bacterial infection. Ma'am, do you want to add anything?
Thank you, Shiba. Exactly. That is the thing. See, common things first. Okay. And then you have some exceptions always. See, allergy, sensitivity, all these happen. So that is maybe 2 out of 10 or 1 out of 10, or maybe like that varies. So that incidence may vary. And that time you use alternatives. Okay. So always we try to say the general standard or the most common, most useful, cheap, as we say, no, the ideal, which fits all these criteria. If that works, yes. But always you have to have alternatives also, because as I always say, no, if everything was simple and straightforward, our profession will be very easy. And that's the challenge what we have, and that is what we have to take it up nicely to manage it. So this is a standard thing, and we have other alternatives, which as we have seen, both Megail and the bides is also used. And as she mentioned, you can add on other ointments with some antibiotic or something like that, depending on what is there. And then also just regular cleaning, debridement, that will help in healing. Okay. So, and then stage of the ulcer also is there. So depending on that, you see and manage appropriately. And I think Dr. Meera was also happy as I saw the response also. Is there anything else? Yes. Does anybody else want to ask anything else? Maggots is something which you also have to teach, because very quickly it happens, and once it happens and it becomes more wound healing management, everything will be difficult. So that also has to be kept in mind. And if you teach them just covering the wound, those type of things will be very helpful.
And in case anyone else is not having anything.
What is the duration of healing in bed sores? Go ahead, Sheeba.
It will not predict. It is depends. Okay, sometimes some patients, some of the patients' skin is very sensitive and very effective, and that time we can able to manage very easily. Sometimes it will take the same. Maybe if you think about third stage pressure ulcer, the same treatment will be effective for one group of patients, but the same stage, same treatment will not be helpful for one group of patients. That time that wound will take 4 or 5 weeks, but the one group patients will take only 2 to 3 weeks. So that is depends. Ma'am, do you want to anything add to anything? But
in
my,
that,
yeah.
No, what you've said is right. I'll just add on. See, you
For
have
my,
you have to just
from my
go ahead.
experience, so I would say like it is depends based on the patient's condition, sign, skin, and the maybe sensitivity. So these are the
Exactly.
three. Yeah.
These are things like basically, as we saw, no, from the risk factors, disease per se, nutrition, everything has a role. Okay. So, for example, you take a patient X who has early stage of the disease, other things are all under good control, and pressure source just was stage 1 or 2. So, and then you have a very good carer, everything available. So you've taught at that stage itself, they started using moisturizing cream, changing position, giving nutrition, giving adequate hydration. If everything is done, the care and response is there. The same thing, all what I've said, stage 4 disease. patient is fully immobile, doesn't have a carer at all, so is lying on one position for hours together. This is all not his fault or anybody's fault. It is just that situation. So it is very variable. And the response, if you put all factors, what we have said, then the response is going to be there. But getting all the factors right always may not be possible. So those are things to be borne in mind. And that is also, that's why, many of these questions, not that the answer is not known. Answer depends on so many variables. It is just not dependent on one variable. So that is why the response also is different based on what is the variable looked into. If everything is looked into, then you get a better. So that is what, like again and again, total, we say that total only comes in for this also. Is that, are we, Dr. Narayanan, are you happy with the response, what you have given, Dr. Narayanan? Thank you. So good. I think I will hand it over to you, Shri Priya. There are no more questions on the chat box.
Thank you, ma'am. Thank you so much. Thank you, Sister Sheeba. I know that personally that you have had a very busy day, even though it is a weekend, and still you managed to join us on time and walk us through such a wonderful session. Thank you so much for that. Thank you everyone for joining in, and with the promise that we'll be meeting again in the next session with yet another different topic and another eminent faculty. This is Sri Priya, along with Sister Sheeba, Dr. Lata Venkatesan, and Mr. Anup signing off from the Tipsico. See you in the next session. Till then, everyone, take care. Bye bye.
Thank you, ma'am.
Thank you, everyone. Thank you,
See you.
Shiva.
Thank you.